Good evening, everyone. Very happy to be here today on behalf of IHW, a not-for-profit organization engaged in the health and well-being of the general human enterprise. Now, one fact that has been proven without doubt over centuries, especially by Ayurveda, is that our health begins and ends in our gut. Modern science has recognized this very well now, and it's centered around it too. If our stomach is not sorted, then all the diseases tend to prey on us. And if we keep it strong and our gut is functioning well, then we tend to be in much better health. This is a proven fact now. Thus, it is extremely important to keep our gut healthy. And when it comes to small children, then too, it is extremely important. In fact, I would say even more important to ensure that their stomach or the gut is functioning well. So today, we have an extremely important topic to discuss with our eminent panelists, GERD in children. A lot of people might not be familiar with the term GERD, but you'll definitely be familiar with some of the symptoms I'm going to mention right now. Burping or belching, not eating, complaining of a tummy ache or a pressure in the chest, being fussy around meal times, vomiting very often, having hiccups, gagging, choking, regurgitation. All of these can be signs of GERD in children, something that we call Pediatric Gerd. The full form of GERD is Gastroesophageal Reflux Disease. We have today with us, and I'm very happy to introduce our very eminent panelists, Dr. Neelam Mohan, who is the Director, Pediatric Gastroenterology, Hepatology and Liver Transplantation at Medanta Medicity Hospital, Gurgaon, and Dr. John Matthai, Pediatric Gastroenterologist at Masonic Children's Hospital, Coimbatore. A very warm welcome to both of you. Let us dive right into the questions because that's where all the information is going to flow from. Dr. Neelam, let me begin with you. Many babies bring out small amounts of milk after feed. It's very common to see. What is this? I mean, really, and why does it occur? I'm sure all mothers would like to know.
Yeah, and I think I'm glad because a lot of people have a lot of doubts, like you yourself, the way you were jumping around with a lot of words and all. I think John and me will clarify quite a lot. So basically, when you have this, let us imagine when anybody eats, it goes from the oral cavity to the pharynx to the food pipe, and then it gets into the stomach.
Yeah.
So normally from the food pipe to the stomach, it should go and should not come back. There are some defense mechanisms, which I will talk a little later. Irrespective of that, when anybody eats, whether it's a young baby infant or a child or a young person or an adult, you will have some amount of food coming back, regurgitating back above from stomach to food pipe. So this word is called the regurgitation or coming back of the content of the stomach, the gastric content, into the food pipe or the esophagus is called gastroesophageal reflux. But in small babies, because the food pipe length is relatively small as compared to an adult, they just spit up or it comes out.
Okay, all right. So I'm sure that clarifies a lot to people who don't understand, for example, someone like me. Dr. Matthai, is there a difference between, I mean, I'm just a little curious, between reflux and vomiting in a baby?
Thank you. I think medically speaking, yes, there is a difference.
Okay.
For a lay person, it's often difficult to make out. So you need to get to a doctor, describe, and then the doctor can tell you if it's vomiting or a reflux. Basically, reflux, like Neelam explained, is a passive process. That sphincter at the lower part of the food pipe or the esophagus becomes lax. So food just comes back. So it's an effortless process. And it involves nothing from the child. It just comes up into the mouth or back into the food pipe, and that's it. Whereas the vomiting is a very active process. So the abdominal muscles will contract, the child will make a noise. It's a very active muscular process that is involved in a vomiting. Vomiting is a much more serious disease or a serious symptom and cannot be ignored. And the best way to differentiate this is to describe what happens or take a video of what happens and show it to the doctor. I hope the doctor will be able to distinguish between the two. Often doctors also themselves have a problem. But it is important to distinguish between a reflux and the so-called vomiting so that you can decide whether something urgent is needed or whether you can wait and watch.
Understood. I think very well explained. I have probably understood. I'm sure the listeners would have understood as well. Dr. Neelam, when should a parent get worried? What situation,
Yeah. That's a very valid question, Kavita. So basically, if you go back to the diagram, if I may ask you to show them. Now, what happens, I was just talking to you about a simple gastroesophageal reflux. I said, everybody has it, you have it, I have it, a child have it. But when these symptoms related to this reflux get aggravated and you have problems related to the reflux, then we call it gastroesophageal reflux disease. The word disease we use in medicine for anything which we think is abnormal. So gastroesophageal reflux was to some extent physiological, because I said even normal people have it. Thoda sa. But when I say gastroesophageal reflux disease, so as John says that the demarcation between reflux to reflux disease, an expert will be able to make. That means these symptoms are more than you would have just allowed it to a spitting or in a small baby, as you were asking me. In that case, if the symptoms get worse, for example, if the child is vomiting a lot and because of that not gaining weight, or is the child very irritable and the child is having some blood in the vomiting, and these are the symptoms where you are not thriving well and all that, we do get worried. And I would like to bring some few things to the attention of parents who are listening to this program. Is besides this typical symptoms, we do have symptoms which are beyond the esophagus. Sometimes the baby arches the neck like this. So that should be considered abnormal because they are trying to increase the probability of vomiting and arching back. So that's not a good sign. Similarly, they can choke. So if somebody has choking on feed, which, actually the milk came up, that cannot be ignored at all. So this choking, and then child can have a little ear infection or wheezing, chest infections, pneumonias. So these are the extra things that a child can get, and a baby can get, where I think the parents should understand and not think that it is just mausam badalne se ho gaya or pneumonia ho gaya. Just they should tell the doctor that my child had been refluxing a lot or vomiting, and the doctor should realize that the weight gain was not adequate and these things, and then describe it as reflux. So if in the first slide, I was just telling you that what is the protective mechanism. So basically God has made this, like if this is the food pipe, let me use a green color. If this is the food pipe and this is the stomach, it's basically the lower end as a sphincter. So one, that muscles is there. Two, the diaphragm. There is a muscle which separates your breathing system from your abdomen. So that also helps you in that. Third, this is not straight. It's little in an angle. So that, it's called the angle. So these. And then the food pipe. This mucosa is such that it has a faster movement of the food pipe. Anything comes up, it should move first and clear it. So the way the foot pipe is moving or the mucosal resistance, these were the 5 protective factors that God has actually created. For some reason, if your peristalsis is low and this resistant, and that's when you end up with a reflux disease.
Okay. All right. So not to be taken lightly at all if these symptoms are there, which ma'am has mentioned. And there is absolutely no harm in speaking to a doctor. And as she mentioned, making a video is probably the best way to show it to the doctor what exactly is happening.
One of the things, I remember when I came from after my training from England 2 decades back, it was even the neonatologists at that time didn't realize if the child gets up and cries a lot and is irritable a lot, especially in nighttime or when lying down, that could also be a manifestation of reflux disease and needs an attention if your weight gain is not there and the child is crying excessively, especially in a lying down position.
Wonderful. So that is also to be looked out for. Dr. Matthai, in case the reflux is not that severe, it's just a normal child growing out well, but there is, like ma'am mentioned, reflux, normal reflux, which happens in most people from time to time. Is there something, if it is really distressing the mother, is there something she can do to, reduce the reflux in her baby? Are there some steps she can take?
See, a reflux, when we call it as not a disease or physiological reflux or
Physiological, yeah.
Most often you find a happy baby and an unhappy mother. So what the mother needs to realize is that as long as her baby is happy, she can remain unhappy if she wants, but you don't need to do anything. You need to intervene only if the baby is also beginning to get unhappy. Like Neelam said earlier, the reflux that occurs depends on the movement of the peristalsis in the foot pipe, the angle that forms between the stomach and this foot pipe, esophagus, and the content that is inside the stomach. A liquid will reflux or come back easy. That's common sense. Whereas if it's little thick, it cannot come back. So one thing you could do if the child is more than 3 or 4 months is to thicken the feed a little bit. Next, you can position the baby so that the baby is not flat. If you put a baby horizontal, flowing back from the stomach to the esophagus is easier. So you keep the baby vertical. Don't fill the stomach. Don't overfeed the baby. When you fill the stomach, the liquid will reflux back because the stomach is full. So feed half, less number of feeding. So positioning, thickening the feed, as well as reducing the volume of feed is what a mother can do in case she feels that something has to be done. But if you, like I said, if the baby is happy, I would suggest that the mother can ignore it.
Stay happy. The mother can stay happy as well.
That's it. Look at the baby, we smiling at you. That's the end of the story. Don't bother.
Wonderful. Okay. Dr. Neelam, you did mention about choking and, certain other symptoms. Can reflux be, I thought maybe we could just stress upon this a little bit more for the mothers who are listening, and even the fathers, in fact, who are listening. Can reflux be life-threatening?
Absolutely. I think it is a very good question, though rare. But all of us want to say, like in the Western world, you hear a lot about SIDS. SID is sudden infant death syndrome. And that's why now it's a protocol that children, babies, especially in the Western countries, they used to be left alone or they used to be put prone, and they have that alarm system because parents like to sleep in different rooms. So in India, these sort of problems we see less because most of the time the parents are with the baby. Having said that, there is always a risk that you're sleeping and you don't, see. So children who are high-risk factors, like premature babies, obese babies, babies who've had a surgery, like thorax surgery, because of, by birth, they had some atresia, foot pipe was not fully formed, or they had some communication between foot pipe to chest, like some surgery which happened in the chest or the abdomen. And as I said, the parents had history of reflux. disease. So these 4-5 risk factors, prematurity, surgeries, obesity, parents, you need to understand that they are very high risk factors and you've got to watch them for symptoms of reflux. A. B, even though John was talking about the various ways of reducing reflux, you notice he never used the word keep the child prone. Though we know if you keep prone, it will be less. We just say that maybe you can keep on a left lateral position and not prone, because that can be bad and sits. And the third thing that I wanted to say is that suppose the reflux came up and I said the baby is small, premature, small, and it came right up till there and the baby choked. So that's called apnea. You must have seen the baby loses voice or becomes breathless so if the baby is breathless less than 3 seconds, or 3 is a lot of seconds, 1, 2, then it's okay. But beyond that, it could be life-threatening because you won't get the oxygen and all that stuff. Second, as I said, if the baby actually ends up swallowing after that, it goes into the aspirating, rather it gets into the windpipe. Because it gets into the windpipe, you've aspirated. So in Bado mein, khate, sometimes people cut you, they say you don't talk. That's called aspiration. So the baby actually aspirated. And when the baby aspirates, you can again sort of have this respiratory apnea symptoms, pneumonia. And then pneumonia can be life-threatening too, because it's a chemical reaction to start with, but then it can get superimposed with infection and all. So though we are saying that majority of the time reflux is physiological, but in a small proportion of children, you will find reflux disease. And those who have reflux disease, again in a small proportion, you could have respiratory symptoms, apnea, etc., or blood in the vomit, which is suggesting that the mucosa, because the pH of the stomach is 4 to 5, whereas the pH of the foot pipe is 7. So sometime when that acid is coming up, it hurts the foot pipe and you can get ulcers and all, but life-threatening with respiratory and apneas.
Which is why it's so important that we're doing this today, because all this information will prepare the parents. At least they'll have the right information and they can take corrective action if needed. It's really important. So I'm very glad. Thank you so much. Dr. Matthai, how does it work? These small little babies, if we are suspecting a reflux issue, serious reflux issue with them, are there any investigations that need to be done? How does one move forward in this?
I think the best investigation is to see it. That's what I say. This is what I call an eyeball scan. That means instead of doing a CT scan or MRI scan, you see it. Feed the baby, get the mother to sit and feed and see what's going on. That is the best investigation. If the parents are otherwise not able to bring the child, record it and show it. But you need to see it and then decide whether the child needs any investigation, because everybody refluxes. There's nobody who doesn't reflux. So putting in something and then looking for a reflux is very unphysiological. See, that really doesn't make sense, because like Neelam said in the beginning, everybody refluxes. The issue is, does that reflux cause a disease?
Yes.
In general, we are worried if that reflux results in the baby losing calories. That means bringing out whatever baby has taken in which case baby fails to thrive or gain weight. Or if that reflux state, that means what reflux is out, goes into the respiratory passages. That means interferes with breathing, goes into the voice box or into the respiratory tree, it's going to be very difficult. So the investigation will depend on first making sure that it is a reflux.
Mm-hmm.
Second, that reflux is pathological, that is, it is a disease. And third, what disease is it causing? Is it causing a disease in the lungs? Is it causing a disease in the esophagus? Is it bringing out the calories all the way out? So depending on that, which I think is beyond the scope of the discussion, all I want to say is that refluxing or GER is a clinical diagnosis. The doctor needs to see it first before you decide whether you need any investigation. And less than 1 out of 100 babies will actually need less than 1 out of 100, will need investigation. So remember this, it's a clinical diagnosis.
Understood. Very well understood.
So, Kavita, that message was very clear that with a population of India, even if it is 1 in 100,
that's a lot.
The message, I think, if the doctors are also seeing, they should learn to refer to a specialist.
Yeah.
This branch of pediatric gastroenterology has really developed now over the last 2 decades, and especially speedily in the last decade. Earlier, all these cases were seen by pediatricians. So I think there is a place for the parents to understand that there could be one unlucky one in them where the child needs investigation, like maybe an endoscopy or a scan, technetium scan, or a impedance pH metry. All these facilities are available in India. Gone are the days where you need to panic. Every city, every district, most of them, they can refer and they can do. So that understanding is very important in them, that you need to investigate. I had a patient where people were abusing that this was apnea, was seizure, and the patient was given anti-seizure medications. But the child had this apnea, and one incident, I remember the parent had lost the child, and that's why they were very vigilant with the second child, and that's how they came to me. So these are some mistakes where we just want to let you know that there are experts. Please approach them and do it. And we can quickly wrap up on more information for parents on how to treat, etc.
As ma'am says, there is enough help available. You just have to seek it, and you have to seek it from right people. So that's a very clear message going out today to everybody who's listening, and to everybody else they can spread the information to, that help is available. Technology is there. Doctors are there to solve this. So there is absolutely no need to panic, as ma'am said. Ma'am, does it worsen or does it improve as the babies grow? I mean,
actually, the good news is it improves. So most of the statistics, they show that the peak comes around 4 months. And that's why, which John was saying, that you can use thickeners. That is the time actually on a peak, because sometimes even though the baby is happy and the mother is unhappy, because I'm a mother, and if my child spits and spoils the dress 10 times to 20 times, for me to clean, especially in winters, and make that might become an issue. So it's sometimes when there is a messy baby, then these thickeners, etc., are needed. But the good news is that by 6 to 8 months, quite a lot, 60% improve, and 88 to 90% improve by a year. So, those sleepless nights of parents, you can be rest assured that things will improve, because as they grow old, the sphincter and everything gets better and better, mature, develop, your food pipe grows, etc. Yeah. So things improve, and you start giving them maybe a bit solid foods, etc., and not predominantly liquids. So that's how they 90% improve. So unlike an older child where things are different, this is the good news with babies, that 90% will outgrow by a year.
All right, understood. Dr. Matthai, a very common question that I'm sure is going on in everybody's mind right now is there a connection between reflux and bottle feed? I mean, is it more in children who are bottle fed? And is there any role for changing or switching to hypoallergenic formula? Is there any good news related to that?
I think, yes, it is more in bottle fed.
Okay.
Because in breastfeeding, there is a limit to the amount of milk a mother can produce and the baby can drink.
Okay.
It's a natural way of restricting the amount of milk that goes in. Whereas bottle feeding, there is no end. You can fill the bottle and go on giving the baby. And if you don't feed the baby properly in a bottle, the baby also ends up swallowing a lot of air. So yes, it is more in bottle-fed babies. So you need to have a rough idea of how much your baby's stomach can hold. And don't overfeed. Right? That's the most important thing. The problem is not with the bottle, it is not with the milk. It's got to do with the volume that is being given and how it is being given.
Okay. So
is there a necessary to switch to a hypoallergenic formula? The answer is a firm no in capital letters.
Okay, so that is very clear. There is no need to
No
do
role
that.
to change. It's nothing to do with the formula.
No, okay, wonderful.
Extremely rare. I mean, I'm not saying no, but for all practical purposes, for a general audience, the answer is no. The yes is for specialists and things like that.
All right. We can now probably talk a little bit about older children, because I'm sure a lot of listeners today would
And we
want
have
to know,
only
does
20
it
minutes to go, so we've got to just get ourselves into the fourth gear or the fifth gear.
Yeah. So does it occur in the older children also? And if it does, what are the symptoms, ma'am?
Yeah. So I think now we'll expedite. I'll be faster too. That in older children, it is almost like adults, nearly symptoms. In small babies, we were talking to you, irritability, night sleep, blood out, all that stuff. So in children, basically, we divided again into two symptoms. Symptoms related to the food pipe and extraesophageal symptoms. What are the symptoms related to food pipe? In your introduction, you were saying, so we tell more, not necessarily belching. We say nausea, vomiting, water brush, muh mein khatta pani aa jana. And when you get up in the morning, bad smell in the morning, some dental erosions because the acid is there in that. So this is very important thing parents should see. If you see multiple dental erosion in your child and your dentist wouldn't understand, do go to a pediatric gastroenterologist. You might be having reflux disease. Besides that, if the child keeps having recurrent ear infections, recurrent sinusitis, recurrent wheezing, which is especially more not getting control with the typical symptoms that the doctor is giving, or pneumonias, which you think have been a little more than you would have expected a child even with infection, then we always, an expert would like to investigate. I'm not just saying you need to treat, but in extraesophageal symptoms and these that you need to see. But any child, they can come to you with heartburn, which typically adults, you and me, I'm sure everybody who's watching have experienced chati jalna, heartburn, all of us have had it. We've eaten some naughty meals and heavy meals, and we've experienced. So those type of things. And then sometimes the older child doesn't want to eat. So this eating problems, and if these could all be a manifestation of reflux disease. So that's how I would simply put it.
So I'm going to straight away move on, Dr. Matthai, to this because you've already explained that about how investigations are to be done. I'm sure it's similar for the older children as well. Maybe we can just talk about the possible risk factors for reflux in older children.
I think the most common risk factor is obesity.
Obesity, all right, I thought
it's probably the one big risk factor for reflux in our child. Second, medications, drugs, important cause of reflux. And plus eating junk food. Because in the end, a lot of reflux is dependent on what goes in through the food pipe into the stomach. So if you eat, like Neelam said, once in a while, it may be all right. But if you're going to make it a habit, then you're going to find that the stomach doesn't agree with it. That's what I call intolerance. All of us have intolerances to various foods. So if you take something that you're intolerant to, the normal peristalsis, that is a one-way process. That means the food keeps going down and down. For the benefit of the people, food doesn't move down the intestinal tract by gravity. It moves by an active process of movement called peristalsis. So if you have an intolerance to a certain food, like a junk food or whatever you eat outside, this normal peristalsis that is one way just goes haywire and it starts going up and down. There's some comes down, some goes up, and then you reflux and the acid in the stomach comes up. So these are all the risk factors: obesity, drugs, and junk food, etc. Which basically means that handling these becomes more important than trying to treat the reflux. That means it becomes a lifestyle modification, which is more important for a permanent solution in an older child and an adult particularly, rather than trying to look for an underlying cause. It's not a God-given cause. It's a man or woman or a child-made cause.
Made cause, yeah. As Neelam ma'am said, naughty foods. I hope some children are also watching so that they can understand that those naughty foods could be causing this problem to them. Ma'am, any other lifestyle modifications besides?
Yes, a lot. Sometimes, I want to tell the parents it's not all about, adolescents. For example, they might get into some bad habits. So in adults, though we say alcohol, but sometimes even adolescents start taking that. And they should realize that their body is maturing, the body and the mind, and it's not good for them. And they are addictives. They should shy away from all such things, unlike that. And then smoking, definitely no, a big no. When I say smoking, it could be passive smoking. Some parent, grandparent, uncle, aunt, somebody smoking around. And the passive smoking is I'm sitting there, but someone next to me was actually smoking. So I got 50% of the inhalations from there. So that is called passive smoking. So these are the things that you should ensure. And eating a fatty meal. So when he said junk food doesn't mean only burgers and pizzas and these two. It also means kachoris and samosas, because and puris, what are these? These are deeply fried Indian junk foods, all samosas, kachoris, and maybe what. So just don't look at junk food that they're all only chips and this thing. So both Indian and that, these are heavily fried foods. These are all supposed to be, you need to have a modification. And as he said, obesity, it becomes like a vicious cycle. So eating too much, you should know when to stop. So one of the best thing I think parents teach children is chew 32 times. When I was a child, I was told, and I never understood why they wanted to tell that. I used to get very irritated because people लगता था 6 बारी में तो खत्म हो गया. So the reason why they wanted to say is our ancestors is that you keep chewing, that means you take time. You take time to eat, so the food gets into the stomach. And actually what happens, stomach is like a balloon. So when it fills up, you get a center in your brain, satiety center, enough. So when you're actually hogging, by the time the stomach sends you a reflex, it's enough. You've actually overeaten before you realize that. So these things need to be understood. You need to eat slow. You need to eat small amount. Don't indulge. Don't eat heavy food. Don't eat. And this aerated drinks, cool drinks and aerated, I think that's a big no. Somebody said in a lecture, and I totally agree, the cool drink should be left for cleaning the bathrooms because they've got so much of acid that in case you don't have an Harpic or acid, you can use them. So it's indirectly the amount of acid that is there in these drinks, aerated drinks, is phenomenal. And imagine when your pH is going more low with this acid and it refluxes, how much damage it will do to the poor little mucosa of the esophagus, which is
I totally agree, ma'am, with your statement about the aerated drinks. I hope it registers in the mind of a lot of people today.
Not only that, I think when you have aerated drinks, the air is released. The carbon dioxide and whatever, that comes to the top of the stomach and it has to escape. There's no other way to escape except that the sphincter gets relaxed and it comes out. And you can never have only the air coming out. Always something else also will come
along with it. Yes.
So this is asking for trouble.
Yeah, I think let's move on to some solutions as well, if we can give it to the listeners. Dr. Neelam, what are the different types of acid suppressing therapies available today?
So the term acid, I think first we need to understand this is a stomach cell. So that cell, we call it as a parietal cell.
There's a picture. Is there a picture somewhere? I think there's a picture for that.
So we'll, if there's a picture, fine. So what happens is basically the sight, the smell, and the taste. These three are, they are sensors. These sensors will stimulate the receptors which are there on the stomach cell, which we call the parietal cell. So there are three receptors. Now this is just lifestyle changes. We are talking about, elevating the head, keep the child, don't make the child sleep. So this is also very important that immediately the child should not lie down. I was very surprised. I told the patient ki khane saath raat mein jaldi so nahi jana. So the next time the parent said, "Hum sone nahi dete, sirf letna hai." So now I started saying, "Sona nahi, letna bhi nahi." It is din mein aur raat mein khana kha ke, they sleep in the day and night, which is really bad. Don't do that. Eat less and don't lie down. And then weight loss and all that we were talking. We've discussed this.
So I was just go to the next picture. Go to the next picture.
this acid we can discuss. Now we have only about 7-8 minutes left.
Yeah. So the 3 receptors which are there, and then there is a drug called ranitidine. Now ranitidine is H2 receptor blocker. There were other drugs, famotidine, cimetidine, which are not so popular like ranitidine. So this is a H2 receptor, one of the 3 receptors I said, which are there, muscarinic, let's forget their names. I'll just remind. So one of them is the gastric one, the H2 receptor blocker, ranitidine will act. And then it gets into the stomach cell, it makes an acid and it comes out and releases from the cell. So there is a PPI, proton pump inhibitor, it will act at this, where the acid is coming out at this level, it is acting. So therefore, this is stronger. This is stronger because all the 3 receptors, whatever they produce, the acid, it comes here, it is blocking. So the advantage with PPI is that it is very good for severe condition and it totally, reduces the acid. But the advantage by using ranitidine, which acts only on one receptor, is that it is less potent, it is mild, and it is not related to, food. And the onset of action is pretty fast as compared to PPI, where you need some levels to be built up. And so once in a time when even older children or adults have symptoms, it is better to use such drugs. But if you have severe reflux, like both of us were talking about a reflux disease, then in that case, older children, we go for a PPI therapy, which is called proton pump inhibitors. To name a few, omeprazole, esomeprazole, lansoprazole, pantoprazole, all the zoles which we are, these are the different trade names. I'm just giving you the chemical names.
Understood.
These we do. But when it comes to less than 1 year, we usually use either ranitidine or we use esomeprazole. These are the 2 drugs that we use, and we don't use the other drugs.
And how long, ma'am, does it take how long do you really need to treat babies? Is it like a really
there is like a step-up therapy and a step-down therapy. Both of us can be right. Step-up means you start with lifestyle modification. Then you go to like one receptor, ranitidine. Then you go to a PPI therapy. And then you go to a high-dose therapy. That's called a step-up therapy. Some people start with PPI and then do and then come down to that. But I'm sure John will also talk about the long-term consequences of drugs. But generally, we like infant, we don't like to give a trial. We like to do diagnosis by test, leave it for the expert. But for older children, we do give trial of PPI therapy and we see them after 3 weeks. If they're doing very good, we extend it to 6 to 8 weeks. But we do not go beyond 8 weeks. And after 8 weeks, when you stop and the symptoms recur, refer to an expert like a pediatric gastroenterologist, like both of us, and we'll need to see why it did stop. So that was called like an empirical therapy. I gave it a trial, but you can't keep trying because you all need to understand that medicines also have side effects. And instead of spending the money on the medicines, it's also important to understand what you're doing if it is not responding. So that's when the role of an expert comes. But this presentation was just to give you an idea that they do have long-term effects, like, your acid can be decreased, so you could have more infections, you could have some absorption of calcium could be less, B12 could be less, calcium deficiencies, osteoporosis, all this. And you've met, I'm sure, a lot of friends who are just addicted to PPI therapy and children. So it's time first to understand how to stop it. And as John was saying, without lifestyle modification, just giving this therapy, that I go on eating heavy food and I take an acid to reduce it. That's not what life is about. I need to first learn what right to eat. As you said, gut is more important, and how to exercise, how to reduce weight, how to behave when you want to eat. These are all related to reflux. Basically, reflux disease and is like, it's like the body is shouting and saying,
need help.
I need help. And it can be prevented with so many lifestyle measures than medicine. So it's a very important thing that even people go and buy over the counter these drugs and take, which is unlike in the Western. So it's not really good. Understand when you a drug. One of the disadvantage of ranitidine is that you can't use it for very long because it gives rise to tachyphylaxis.
Okay.
That means beyond 2-3 months, we don't suggest. And we assume you will outgrow the need by that time.
Okay.
So,
just one last question we have time for. I thought if Dr. Matthai, this is something that I'm sure everybody wants to know. Does the household remedies like ginger, lemon, ajwain, and other mildred Ayurvedic products, are they safe for use in such conditions? I'm not talking about adults. I'm only talking about children. So for them, is it okay to give them?
No. If a child has a reflux disease, that has got a pathological basis to it. And medicines are only a part of the treatment. Even in an antacid, an anti-acid that we use drugs, they do not reduce the reflux.
Okay.
Reflux goes on. We are only converting an acidic reflux into an alkaline reflux.
Achha.
Right? A child has a reflux, the acid comes up, damages the mucosa, damages the respiratory tract, damages the voice box, is what gives rise to the symptom.
Okay.
You don't reduce the reflux by cutting down the acid. The acid is only the cause for the damage to the respiratory tract. Antacids do not reduce reflux, right? They only convert an acidic reflux into an alkaline reflux. That means you will still reflux, but it does not cause any disease. So this is why just for a plain reflux, putting a child on an antacid is not an option, unless you think the acid is creating a problem. This is why even when you put them on an anti-acid therapy, lifestyle modifications or positioning, thickening of feeds and all are still important. It's not a question of one rather than the other. Those are important, plus acid. To add on to what Neelam said, acid is something that I like to say is an evolutionary advantage. The lower animals don't have acid in their stomach. And God in his wisdom or her wisdom has put acid there as a protective mechanism for the stomach. That's the first line of defense that our intestine has against all the muck that goes in, the bacteria and the virus. So cutting an acid off is exposing your lower intestinal tract to all the germs of this world. So be careful when you cut acid, and do not cut acid with any drug unless you have a valid reason to do so. And that again should be for a limited period of time rather than forever and ever.
Okay, understood.
First message I would like to give, Kavita, sorry to interrupt, is that people don't realize some of the drugs can give rise to, some antibiotics they keep taking.
In fact, this is a question that has come up from the listeners as well.
So
you could clarify this.
When you're using antibiotics or you're using painkillers, like anything, brufen, ibuprofen, and naproxen, these acids which we keep using as these can also give rise to reflux. So you need to balance all that. And remember not to, expose yourself to such issues.
Just one last question. I really had
the question about antibiotics with antacids, Ms. Kavita?
Yeah, sorry. Could you repeat that?
A question from the audience about antibiotics and antacids?
Yes. I was coming to that.
The answer is no. Most antibiotics, you should not give an antacid.
All right. Because this a lot of people are asking.
It's about painkillers and things like that. Those are drugs which increase acid. That's a very small number of drugs. Painkillers, steroids, a very limited number of drugs which will increase acid production. Only they need an antacid.
Because a lot of people think, that what you give to the adults, the anti-acid medication can be given to the children, which is so wrong.
No, what I wanted to highlight is that unnecessary use of antibiotics should be avoided. Parents should remember that just using antibiotics itself can give rise to problems of acid and all that stuff. Shy away from the use of antibiotics. I've seen parents, so many parents, educated. I remember my children when they were studying in school, colleges, all their parents, first day of runny nose or the child is on antibiotics. These things, it's a total shame that the whole country is shouting aloud and telling you all, don't misuse antibiotics, because we are getting into antibiotic resistance, and antibiotics give rise to obesity. Huge studies have shown, because you destroy your gut microbiota, they destroy your gut flora and give rise to all, problems of obesity, acidity, etc. So my purpose of saying that was that don't use them unless it is, really
Absolutely
necessary by an
necessary,
expert.
right.
That was it. And the very good message which John wanted to say is that don't assume that all antibiotics need a reflux unless they were using or something like, as he said, steroids or some bronchodilators where the doctor thought it was necessary. But the young doctors who are emerging, they've just become a habit to keep writing that.
Wonderful. I think on this note, we will end this, and there are a lot of important lessons today learned. Health begins in the gut and ends in the gut, as everybody knows, and it has been reiterated again and again today. Overuse of antacids, antibiotics to be completely avoided, GERD not to be taken lightly at all. Please show your child to a specialist. You cannot take that risk. It's as simple as that. And as again it has been reiterated, there is no need to panic. It can be handled very easily. You just need to make sure that you get the right treatment for the child. Thank you very much, Dr. Matthai and Dr. Neelam. Wonderful discussion today. I have learned a lot. I'm sure everyone who watches this video will learn a lot too, especially parents. And I'm sure they'll be relieved after getting so much right information. Thank you very much for coming in today.
Thank you very much. It's a pleasure attending this program. And
we would like to thank all the organizers who were involved in this platform, though it was an NGO and that thing. Thank you so much for having us over.